Good morning. It's good to be on. And if the slides can be made to work properly, let me get started. Again, I'm Glenn Morris. I'm a physician specialist in infectious diseases, but also an epidemiologist with a great deal of interest, clearly in issues related to infections, but issues in general related to health and safety of the agricultural workforce. And again, what I'd like to do today is to provide a little bit of background in terms of COVID-19 and also talk briefly about the relationship with the agricultural workforce. If I can have the next slide, please. Just by way of background, coronaviruses are species of viruses belonging to the subfamily Corynodiridae. They look like this. These actually are electron micrographs that were done by a group at University of North Carolina, published in New England Journal. And you can see, you normally see the type of picture that was on my initial slide, but these are real viruses. And you can see them clustering around alveolar cells here in the lung. Next slide. So where do these things come from? Probably originally from bats. They're actually pretty common in bats. And in fact, as you all know, we have bat houses here on campus at University of Florida. And we've actually isolated coronaviruses from the bat houses, not the coronavirus, the SARS-CoV-2 that causes COVID, but clearly bats are a carrier for this virus. This virus is also actually fairly common in domestic and wild animals. It's a common cause of illness. It's an economically significant infection in some certain farm animals, including porcine coronavirus, bovine coronavirus, both of which both result in diarrhea in young animals. It's pretty common in humans. There is a fair chance that everybody on this call has at one point in your life been infected with a coronavirus. There is the group called alpha coronaviruses. There are two of them, 229E and NL63, that are a common cause of upper respiratory infections that are sort of like the common cold. And then there are what are called the beta coronaviruses, HKU1 and OC43. But then the reason that this gets attention, and if I could have the next slide, please. Go back, sorry. Try back once more. Is really the three that are here at the bottom, which are SARS, MERS, and COVID-19. So next slide. This is actually data from here at UF Health in Gainesville. And this is a listing of viral respiratory pathogens that were identified during the first week of February of this year. And I simply had them pull this list from the clinical micro lab. And the main reason is to point out that you see all of these four human, what are called human coronaviruses listed on this list. And basically, they were causing severe enough upper respiratory illness that people in the emergency room elected to send in assays to screen for viral pathogens. And so essentially, what you see is that these viruses are around all the time. And as I said, they're viruses that we as humans pick up without too much difficulty. Next slide. The bad ones include SARS. And SARS was first identified in 2003 and 2004. It has not been seen since. At the time of the SARS outbreak, it was reported from 29 countries with over 8,000 cases and 774 deaths. Sounded like a lot at the time. Right at the moment, it sounds pretty trivial compared to what we're seeing with COVID. Major outbreaks in Hong Kong, Canada. Zoonotic lynx, again, probably originated in bats, moved into palm civets. That's a palm civet shown on the slide, and from palm civets into human populations. MERS-CoV was identified in September of 2012. currently reported from 27 countries. Not that many cases, close to 2,000 cases. Major outbreaks are in the Middle East. Interestingly, there was a big outbreak that occurred in South Korea. Its zoonotic links, dromedaries. For those of you who are not up on your camels, a dromedary is a one-humped camel, shown in the picture here. And apparently the virus has passed through secretions and raw milk to humans. Next slide. And this is just simply sort of a family tree, phylogenetic tree of coronaviruses. You will see the top arrow there, the lighter blue. Those are the MERS-CoV strains. A little farther down are the SARS strains. You'll see they're all intermixed with bat strains. And then in red are the, what we now call SARS-CoV-2, or the cause of coronavirus. And notice that the closest related strain that we've got there is a bat strain. So again, it's likely that this was a strain that originated in bats, probably moved through some type of mammalian host, and then moved into human populations. Next slide. And it did indeed move into human populations. This is a diagram from the WHO webpage. These are data as of yesterday. And what you see is that, interestingly, although this originated in China, which is what's shown under Western Pacific, where the bulk of cases have occurred, this is the daily case number reported to WHO, where the bulk of cases have occurred is in the Americas. Between the United States and Brazil and other parts of South America, this is where the disease has really taken hold. You will see most recently there are increasing numbers of cases in Southeast Asia. Europe is holding pretty steady. Eastern Mediterranean dropping some. But again, we're really talking about the Americas, and again, in particular, Brazil and the United States. Next slide. And this is Florida. Again, what you see is that we had an initial blip in cases back in April. These are data from the New York Times webpage. In June, with the letting up of some of the restrictions within the communities, we saw a major upsurge of cases. Peaking in mid-July, there has been a gradual decline since that time. However, in the state, we've had over 650,000 cases, over 12,000 deaths. And while the overall case numbers are down substantially, we are still seeing a substantive number of cases overall within the state of Florida. And I might mention, for those of you who are here at the University of Florida, we are, as is every other major university, seeing a substantial uptick in numbers of cases in our university students as they come back to campus. We hope we've got it under control, but clearly the numbers are increasing, and clearly there are concerns about increasing numbers with the opening of schools. And my understanding is the bars will be reopening on Monday, which may further exacerbate this. So I think the point to be made from this is that we are not out of the woods. We still very much have a COVID-19 problem here in the state of Florida. Next slide. All right, let me talk a little bit about the virus. I think the thing to emphasize is that it is highly contagious, and basically it is, transmitted through a respiratory route. There's been a lot of talk, particularly at the beginning, about deep cleaning and this sort of thing. Yes, environmental sanitation is important, but I think we are becoming increasingly aware of the fact that clearly the major transmission routes are through a respiratory route. And what you see here is a diagram that talks about different sized particles. When you talk or sing or speak loudly or cough, you expel particles from your mouth. And if you're infected, those particles can contain the virus. Now, if they're large particles, they'll fall out of the air within a meter or two. And that's where we came up with the 6-foot rule. That basically within 6 foot, a lot of the large particles have fallen out. but it's not a, you're safe at 5'9", but you're at risk at 6'3". It is a continuous variable. And in fact, probably up to 12 feet, there continues to be a risk from larger droplets, larger particles. And the rough rule of thumb is that for every 3 feet you move farther away from a person, you drop your risk in half. The risk does not magically go away at 6 feet. And so I think that needs to be kept in mind as we talk about worker safety. The other thing to emphasize is that we have become increasingly aware of the importance of aerosols. There are now multiple anecdotes of, once, folks singing in a room, everybody in the room gets infected. Really, all it takes is one infected person who is expelling large numbers of viruses within a room, and they can infect everybody in that room, 6 feet or not. And so again, I think there needs to be an awareness that closed spaces are a major problem. And we are becoming increasingly aware of the risks associated with closed spaces. I would also note that the virus can clearly be transmitted by persons who have no symptoms. In fact, probably the highest rate of excretion may well be in the 24 to 48 hours before onset of symptoms. So even though you may be totally asymptomatic, you may be excreting large numbers of viruses. And the large numbers of viruses being excreted continues for the first couple of days of illness, and then drops off fairly rapidly thereafter. But it's that time period right before onset of symptoms, right after onset, or in persons who are asymptomatic, that you get the major risk for transmission. Next slide. So talking about aerosol, actually we've done a lot of research here at University of Florida on aerosols associated with coronaviruses. One of the studies we published actually a few years back took advantage of a machine that was invented in part with the assistance of engineers here from the University of Florida that is designed to pick up viral aerosols and is actually probably the best way there is to do it. In a study we did a couple of years ago, we parked one of these machines in the waiting room in the reception area of the student infirmary here at UF. And what's shown is the list of viruses that we pulled out of the air from the air of the waiting room of the Student Health Service. However, now that we're in the SARS-CoV era, actually we did the same sort of thing in a patient room. And basically what you see are two patients in a room. Actually, patient number 2 was probably not continuing to excrete the virus. Patient number 1 was still infectious, had just been admitted to the hospital 24 hours before. The machine is over on the far back corner, about 20 feet away from patient number 1. And sure enough, we isolated the virus from the air in the room. This paper actually has gotten a fair degree of national attention because this was the first time we'd actually been able to culture the virus from the air of the room of a patient, at this point, like I say, about 20 feet away. And we were able to grow the virus, sequence it, and show that it had an identical sequence with the patient. So we have a high degree of confidence that we were picking up the virus in the air at some distance away from a patient. I would note that there were no aerosol generating procedures being done. The patient really wasn't coughing that much, just sitting there quietly laying in bed. And we got the virus 20 feet away. Next slide. All right, so clinical presentation. The typical cases, fever, cough, these symptoms come from the first 1,000 or so cases reported out of one of the major medical centers in China. Interestingly, probably the most characteristic symptom is loss of the sense of taste and smell. When a patient comes in and says that they've lost the sense of taste and smell, it's 100% they've got COVID. Not all COVID patients have that, but it's an extremely characteristic symptom. A lot of this other stuff is very non-specific, which is what creates problems. So you can have patients who come in who may have non-specific upper respiratory symptoms. And just based on a clinical evaluation, it's really not possible to say who has COVID and who doesn't. Severe cases are not that common, but when they do occur, what we see is worsening of symptoms over subsequent days, hospitalization usually occurring around average of 11 days after exposure, increasing shortness of breath. I think what I would emphasize, however, is this is not just another case of the flu. It's not just a respiratory virus. This virus gets into all parts of the body. You get into the lungs, respiratory failure, fibrosis of the lungs, but you also get involvement of the brain, heart, with potential myocarditis, kidney, liver, GI tract. The virus gets into the lining of the arteries. The photomitograph there actually is from a paper written by one of our faculty here at the Emerging Pathogens Institute here at University of Florida, where they are able to identify the virus inside the cells lining arteries in the brain. Obviously, to be able to get this sample, we were not dealing with a live patient. This is an autopsy sample, but what it does is highlight the fact that this is a really nasty virus and can do some really bad stuff to folks. However, the other thing I would mention is hypercoagulable state. What we find particularly in the elderly is that frequently patients present with strokes and heart attacks. And then incidentally later on, although these days we test them immediately, are found to have COVID. But that essentially what happened was that the COVID caused a hypercoagulable state, which in turn caused a stroke. And the stroke is the presenting symptom, not the respiratory infection. But then once they come in with the stroke, then we go back and find out, oh yes, they did have COVID. So the hypercoagulable state is a critical issue. I would note, however, that up to 50% of infected persons in large population-based studies are asymptomatic. Another 30–40% have only mild symptoms. But if you are in the category at high risk for severe disease, this can truly be a devastating disease. It's not just the little flu. This is a really, really bad disease that can do bad things to significant portions of your body. Next slide. So what are the risk factors for more severe disease? Age is probably the most important risk factor. Here in Florida, these are data from yesterday, 86% of deaths and 46% of hospitalizations, but only 12% of cases were among persons aged 65 years and older. So clearly, there is a substantial increase in risk for individuals who are older. However, and these are criteria from CDC, there is strong evidence of increased risk for patients with cancer, chronic kidney disease, COPD, immunocompromised, obesity. This has really emerged as a major risk factor. And I would note that we're basically talking about having what's called a body mass index of 30 or higher. Just being overweight gets you into this category. It's not the grossly obese. It's if you're a little bit overweight, you begin to merge into this category of high risk. Some evidence, asthma, hypertension. I will mention briefly pregnancy. Next slide. Because particularly when we're talking about agricultural workers, frequently we're talking about families and kids. CDC surveillance, data from 8,207 COVID-19 positive pregnant women. Next slide. After adjusting for age, what we see is that there is a significant increase in the likelihood of pregnant women being admitted to the intensive care unit, and they are significantly more likely to require mechanical ventilation. There is not an increase in death rate, but clearly there is substantially more severe illness. Next slide. So how do you detect this particular virus? There are the genetic approaches which actually detect the virus, the presence of the virus itself. And these are the tests we need when we're trying to figure out who's infected and who has the potential for spreading the virus. This currently is done primarily by a laboratory test called an RT-PCR. It is, however, a technically difficult test. It requires special instrumentation, appropriate operator safety precautions. There are rapid antigen tests, which have been now approved by FDA. The problem is it basically requires, your firstborn, a promise of your firstborn child or something else to get hold of some of these antigen tests. They are available, and I think as we begin to think about worker safety, really the availability of testing and the availability of rapid testing is a theme that you're going to hear me recurringly talk about over the next few minutes. And again, the key to that is the rapid antigen testing. We just simply need to have enough of it available and to have it accessible. There are antibody tests which are available, which basically look for the presence of antibodies to the virus and are an indicator of whether or not somebody's been infected. The problem with antibody tests is they don't indicate whether you're infectious right this minute. And as somebody who's trying to prevent transmission of disease, particularly in a workplace setting, I want to know whether somebody is infectious right now. And the antibody approach doesn't do that. It generally requires a small blood sample. Frequently, people will talk about this being the prick test. Well, basically just means, you get a finger stick. But the assays that are available are not that good. Reliability of assays is not great. You can buy anything on the internet. It's not clear that the presence of antibodies are protective against illness. Just because you have antibodies doesn't mean that you are not susceptible to reinfection. It doesn't provide a quote unquote immunity passport. That's changing. We are starting to get some sense of what protective antibodies are, but at least for the present time, it's not that helpful. By the time antibodies show up, the person is not likely to be infectious. And reported positives from commercial testing laboratories for the state of Florida show that they're only getting about 6-7% positive. So all of this is to say that most professional organizations in infectious diseases do not recommend the use of antibody testing, at least at this point in time, for evaluation, particularly for workers. Next slide. Yeah, just emphasizing that doesn't provide infectivity. All right, so how do you prevent transmission? What works? Well, social distancing, that's the 6-foot rule. And again, as I said earlier, basically every meter you're further apart, you reduce your risk by half. 6 foot is the magic number, but 6 foot it's a continuous variable. So again, I've been in settings where people are sitting there. Well, actually I was in a store and somebody started walking toward me and became very nervous and said, "Can you please move over a few inches? You're within 6 feet of where I need to walk to get out the door." And it's sort of, my moving over 6 inches is not going to provide significant protection if I indeed was infected with coronavirus. So, the social distancing is important, but be aware it's a continuous variable. Masks work, despite what you may have heard on TV or on the internet. They really do work. The N95 masks, which are worn by medical personnel, are highly effective in blocking passage of the virus. Medical grade masks, which are the types of things surgeons wear, or what we call procedure masks, maybe as much as an 85% reduction in infection. Cloth masks are less effective, but still have some effect. But you need to follow CDC guidelines, multiple layers of cloth, reasonable fit, need to cover the mouth and nose. And I would say that we've done testing in our laboratories here at UF. And one of the things that I would caution is that, what's up there at label number 11, this is actually a picture from a Duke study, but we've done the same studies in our lab. This is what people call a Gator, that neck sleeve that you pull up over your face. Those don't do anything. And in fact, in the study out of Duke, it may actually increase your risk of infection. So if you could advance the slide one, there should be a big X that comes across. Gators don't work. Bandanas, same thing, they don't work. Next slide, and that should also put a big X over that. So if you're going to use a mask, make sure it's a mask that works, and be aware that it's not just any random face cover. And in fact, CDC has now started to say don't use these. Face shields, they are controversial. Maybe some studies as much as 65 reduction in infection, but the data are soft. Hand washing still is important, definitely. There still is the possibility of touching a surface that may be contaminated and then touching your nose and transmitting. And stay outdoors as much as possible. And this gets back to the aerosols. When you're in a closed space and you've got one person who's excreting large amounts of virus, particularly if they're not wearing a mask, you're going to get transmission throughout the entire room, not just within 6 feet. Outdoors, it is much less likely than when you're within a closed space. Next slide. The other thing to emphasize is that the way we get control of this illness is doing what has been called test and trace or contact tracing. And the key first step is to identify infected persons. If you don't know who's infected, you can't put in place appropriate interventions. You need easily accessible testing sites. Down at the bottom are pictures of testing vans that are actually mobile vans operated by the Florida Department of Health. We have talked about using these vans in association with worker safety here in Florida, particularly with migrant worker populations. You basically can drive the van up and they can test 500 people in a day with one of these vans. So these are available and are a critical component of knowing what needs to be done to try to prevent transmission of the virus. You need an acceptable test. Right at the moment, we're still doing what are called nasopharyngeal swabs. For those of you who have been tested, and I've ended up having to be tested a couple of times, that's that swab they kind of stick all the way back to the back of your head. And once you've had one of them, you're not too anxious to have them again. However, here at UF and in multiple other sites, we are trying to move increasingly towards saliva testing. You just spit saliva in a container rather than having the swab. We're hopeful that's going to increase the acceptability of the test. But the key thing is we need rapid turnaround. We've had a period of time where it was taking 5, 6, 7 days to get answers back on tests. If you don't know the answer within less than 24 hours, the data are basically worthless. And that has become a major issue. We've got to have rapid testing, and when one begins to think about development of appropriate strategies to limit transmission, particularly in an agricultural setting, the rapidity of the testing is probably the #1 issue. Now, once you know who's infected, then you can quarantine those who are exposed, isolate those who are infected. And again, the graphs that are shown here are from some mathematical models, but basically what they show is that if you are able to identify, as few as, 40% of the 20 to 40% of the infected individuals and get them appropriately isolated, quarantined, contacts quarantined, you are able to have a substantive impact on overall transmission. And so essentially taking it together, if one could combine widespread use of masks with aggressive testing and tracing, rapid testing, and then rapid contact tracing and quarantining, this is an epidemic that we should be able to bring under control. The problem we have encountered is that we have not been able to actually implement these. There continues to be controversy and unwillingness to wear masks, and there continues to be difficulties with obtaining sufficient amounts of testing and rapid testing. And under these circumstances, we are continuing to see transmission within this country. Next slide. All right, so what about ag workers? These are the key points from the CDC guidelines and the US Department of Labor. I'm not going to go through all of these sort of tight bullet points. I would note bullet point number 4, grouping workers together into cohorts, which is important and an important step. And also point 5 talks about having everybody in similar vehicles, which again, to me is a critical point, which I'll come back to. Next slide. So what's been our experience? Well, the problem is we really don't have good data on overall prevalence of COVID-19 among agricultural workers. What we found, or what we have found from the beginning here in Florida, is that workers are not anxious to be tested, because if they turn positive, they're going to be out of work. And so both from the producer, worker, contractor, and worker level, there has not been overwhelming enthusiasm about testing. We have looked at a couple of situations. We screened a group of farm workers and ornamentals. We got 0 positive out of 60. We in fisheries tested 501 people down in Cedar Key, 2 positive. But then we also had a group of H2A workers. We tested 191 were positive, and I'll come back to those in a moment. And what I would like to do is highlight what for me are the primary problem areas that we need to think about when we're talking about COVID-19 and agricultural workers. Number one is housing. If you've got people crowded together in a single room, sleeping, you are going to have a major problem with transmission. Transportation. If you have 50 people crowded onto a school bus going out to a field, there is a reasonable likelihood that there will be transmission. And if you've got people who are sick or infected and not sick, and who are continuing to work within close quarters of individuals who are not yet infected, there is a high likelihood that you are going to have transmission. Next slide. Next. And let me just give you an example. This actually, these data are publicly available. They actually were reported in the Gainesville Sun. But just as an example, we had a group of about 50 H2A workers who were working down in South Florida, came up to Central Florida to join another group of workers in a single labor contractor. Total work group was about 120. Crew chief was subsequently notified that 2 of the group from South Florida, while they were still in South Florida, had been tested for COVID because they had been symptomatic. And it took a while for the results to make it back up to the crew chief, but that they had been positive for COVID. The local county health department was subsequently notified by the crew chief that multiple persons in this work crew now had symptoms consistent with COVID-19. The work crew was driven to the health department by the crew chief in 2 crowded school buses where we had 100 people that were tested. Again, that's 50 people in a crowded school bus, some of whom may well be infected with COVID. If the rest of them weren't infected, there's a reasonable likelihood the infection was going to occur. It took 6 days for the results to come back. When they did, we found that 91 out of 100 persons, of the 100 persons tested, were positive for COVID-19. At that point, the health department visited the work crew on site, found that many, if not most, had returned to work while test results were pending. Crew members were living in motel rooms. They had 6 to 10 persons per room. They were supposed to have no more than 4, but even with 4, there's going to be transmission. Apparently, some crew members had visited local emergency rooms for care. There was not a good systematic way to provide care to these individuals. And by the time the health department started to gear up to figure out what was happening, the crew was gone. They'd moved on to jobs in other states, and they couldn't be located. These are the types of issues we run into. Next slide. I would note that Michigan has actually put out regulations effective end of August dealing with these, which requires one-time testing of all residents, agricultural employees, migrant camp operators, testing of all new residents within 48 hours of arrival, separate housing for newly arrived residents, testing of any resident, assistance with isolation housing. So there are states that have moved in this direction from a regulatory standpoint. We are not at that level here in Florida. Next slide. The good news from the agricultural standpoint, we do not seem to have any problems with transmission by food. This is really an issue with worker health and transmission among workers. Next slide. And so bottom line, when we talk about COVID, this is a highly contagious virus. There is need for accessible, rapid, and reliable testing to identify cases and monitor transmission. Potentially effective interventions include masks, social distancing, hand washing, staying outdoors, avoid closed spaces. And the problem areas that I think will be coming up in the discussions to follow: housing, transportation, and diagnosis and identification of persons who are infected to minimize the risk of working while ill. And then as a secondary component of that, what do you do with positive workers? How do you quarantine them? Or how do you isolate them? How do you quarantine contacts to minimize subsequent transmission? And how do you assure that there is appropriate medical care available for these individuals, most of whom, at least with the H-2A workers, do not have health insurance and do not have paid days off. So I think there are a number of issues that we need to address as we think about this, and I look forward to the discussion over this session and the session next week. Thank you.
Thank you, Dr. Morris. We have time for a few questions, and if you have a question, please use the Q&A portion of the Zoom. And we have one question in the Q&A currently, which I'll read to you, Dr. Morris, for your response. The question says, Dr. Morris, regarding the aerosol collection from waiting room in the student infirmary and from the COVID-19 patient's room, how long does it take to collect the virus particles from the air? In other words, how long does the machine run to collect those particles?
These were 1-hour sampling runs. So what we did was put the machine in the room, run it for an hour. And then actually what we did was, to make sure we weren't getting internal contamination in the machine, we put a HEPA filter on top of the inlet valve, ran it for another hour, and then took the HEPA filter off and ran it for a third hour. And sure enough, we found that we got the viruses in the times where the first hour and the third hour, but not in the time when we had a filter on it. So within an hour, I think we could probably pick it up in less time, but I think clearly our work and the work by other investigators show that there is viable virus in the air, which can persist for, based on studies that have been done by other groups, for a period of several hours, if not longer, just sort of drifting in the air.
Okay, we have another question in the Q&A. In what agricultural communities have the Department of Health testing vans been doing testing? We have not seen any in our communities. Do you know where they have been doing the testing in ag communities?
I mean, to be perfectly honest, this is something that we are just starting to try to get off the ground. And again, Tracy, as you're aware, we've been working with Nick Place in IFAS to develop appropriate strategies to work with the counties to get these vans in place. And again, particularly as we face a situation with the influx of migrant workers with the fall crops here in Florida, we are hopeful that we will be able, with the cooperation of county health departments, working with FEMA and the State Department of Health, to be able to get adequate testing facilities.
Right, I am part of that task force, as you mentioned, and the Department of Health, FDACS, and UF-IFAS have been working together to get the trucks into counties where we know workers are going to be coming into the county. So that should be happening very soon, and can follow up with more information to the person who asked the question. We still have time for another question or two for Dr. Morris. And while see, another question has just come in. Do you know, this question is, do you know if Michigan has published its standards and protocols regarding how it deals with migrant workers so that we could use it as a template?
Yeah, I mean, it's just go to the internet and Google Michigan agricultural, COVID requirements for agricultural workers. Again, these just came out at the end of August, but the situation in Michigan was such that they felt that it was appropriate to develop standards for their migrant and agricultural workforce. I think what they have put together is actually quite good. I think it's a well thought out regulatory program, and I do think it serves as a potential model for other states as to possible approaches to try to minimize the risk of transmission.
Okay, thank you. We have another question. Is there any sense or idea of the effects of the heat exposure and the spread or intensity of the virus on worker health?
Good question. And you know, there was, at least for the virus, there was sort of this thing of summer's going to come and it's going to disappear. Didn't happen. This virus transmits very nicely under high heat conditions. I think, however, the other part of this question may well be what happens when you have a situation where you have workers who may be exposed, you know, have issues with heat exposure combined with exposure to the virus. And I think that is very worrisome. And I think particularly in Florida, this is of substantive concern. Our problem is that we don't have the data. As I said, what was extremely frustrating with this one episode of H2A workers was that we suddenly became aware of what was going on, and there were a number of questions that it raised, including such issues as heat exposure and the like, because they were working under circumstances where there was substantial heat exposure. But then they just disappeared. And, you know, not to be, I understand labor contractors are working under, you know, tight time schedules and the like, but I do think perhaps we should step back and think a minute about how we can try to get appropriate data and try to make certain we have adequate protection for our workforce.
All right, thank you. We have another question. Could you please elaborate more on the continuous variable regarding the 6 feet? I think CDC recommendations are taken very literally many times.
And which is the reason I bring up this point, is that 6 foot, I won't say was arbitrary, but was sort of picked as something where there was a substantial decrease in risk. Essentially, as I said, the rule of thumb is for every meter or yard away, you drop your risk in half. So if you're at 6 feet, you've dropped your risk, you know, 4-fold, but the risk is still there, you know, and so I think it's not, you know, when you're dealing with public health guidelines, one has to be careful and not make them too complicated. And so 6 foot has become the magic number, but I think at the level of trying to develop policy and thinking about optimizing, you know, protection and minimizing transmission, there needs to be an awareness that there's nothing magic about 6 feet. It's to a degree an arbitrarily chosen distance, but that at 9 feet, you're still at risk, although that's 3 feet more. And so, you know, your risk gets cut in half again. And at 12 feet, you're cutting your risk in half again. But then in England, they were talking about moving it to 3 feet, where you still had a substantial reduction in risk, but not as much as 6 feet. So a lot of this is more simply to make people aware of the fact that, you know, there needs to be some awareness of, you know, the flexibility and the somewhat arbitrary nature of the 6 foot rule.
Okay, so this next question is a good segue and also kind of points out the fact that research is just coming out on so much of this. The question is, the study that folks cite to point at gators being ineffective at best only looked at one gator and appeared to be a study designed around evaluating an assessment tool rather than assessing the actual masked gator. Many folks find them to be the only practical solution for physical activity outside. Are you recommending maskless over gators for manual labor or exercise outside if other masks are not being used?
We have actually tested gators in our laboratory here at UF. We didn't publish our data, but you know, we were interested in looking at the utility of various types of face coverings, in part because the university administration was making things up with branding on them. And I can tell you that at least in terms of permeability to the virus, most gators are made of Lycra type material. Actually, if you hold it up to the light, you can see through it. or, you know, it's not multiple layers of cloth, which is the CDC recommendation. And we found that we got almost complete passage we were doing our studies with some of the benign human coronaviruses that behave just like COVID. We found that, you know, wearing the Gator having the Gator basically provided no protection against, you know, either spread of the virus or in terms of potential reception of the virus. I hesitate to use the word worthless, but I think to a large degree, the Gators are worthless. I think if I had a choice between having somebody wear the Gator and not wear the Gator, I'm not sure you gain that much by wearing it. And if you're worried about heat exhaustion and other things within worker settings outdoors, I might say that if you can't wear a reasonable cloth mask that meets CDC criteria, and again, CDC criteria Gators don't meet CDC criteria. CDC criteria basically require multiple layers of cloth and a close fitting mask. If you can't wear a mask that meets those criteria and you're in an open setting, I'm not certain that wearing the Gators help that much.
Okay. We have another question. What is known about potential for virus contamination of foodstuffs by handling by ag or fisheries harvesters?
It is theoretically possible. It is clearly been of concern. I know that particularly for ready-to-eat products, there have been substantial concerns, which I think are warranted. I will also say that from a hard data standpoint, at this point, we do not have clear documentation of transmission of COVID via food. And both CDC, USDA, and the World Health Organization all have said that food does not appear to be an important vehicle for transmission of the infection. Having said that, I think if you're working with ready-to-eat products, the better part of valor is to indeed take necessary precautions to minimize the risk that the product may be contaminated. But I think that at this point, far and away the great risk is person-to-person transmission via respiratory secretions, and transmission with food does not appear to be a critical issue. And again, as I had on the one of the slides, if you follow the standard practices, good agricultural practices that come out of USDA, they should be adequate to provide sufficient protection for food products.
Okay, this is probably going to be the last question. Farm workers that are wearing masks find their masks are wet with sweat and become dirty within the first hour or so of work. Are there risks of the virus adhering to the masks and or adhering to dirt particles on the mask that could put them at increased risk?
Yeah, I mean, I think once a mask gets wet, it's probably really not that effective. And this gets back to the concept that if you were in an open setting, maintaining adequate social distancing, and 6 feet is, while I've been talking about some of the problems with 6 feet, 6 feet is not an unreasonable rule. I think if you have agricultural workers that are outdoors, maintaining 6 foot distancing, that the masking may not add that much in terms of protection, particularly if the masks get wet and dirty, as has been pointed out. And so I think it becomes to a degree a judgment call. I think that when you are in a closed setting, an enclosed setting, when you're on transportation vehicles, when you're inside housing, if you're inside a shed where you're washing produce or something like that, under those circumstances, yes, I think masks are critical. But when you've got guys out in the field sweating, masks are soaked, I'm not sure you really gain anything with the mask.